Hello, everyone. Thank you for joining today's 2024 Annual Call for Quality and Cost Measures for the Merit-Based Incentive Payment System. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions. You can either submit written questions via the Q&A box, or you can raise your hand to ask a question via the webinar audio. A recording of this webinar and accompanying slides will be shared online on the Quality Payment Program webinar library in about 1 to 2 weeks. Now I'll turn it over to Dr. Dan Green from CMS to begin.
Thanks, Hallie. Welcome, everyone. So glad you all could join us today. If we go to slide 2, we'll see a snapshot of what we're hoping to cover today. We will be providing an overview of the annual call for measures process, and we'll be specifically focusing more on the MIPS quality and cost measures. At the end of our presentation, there will be an opportunity for question and answers. So please write them down so that you remember to ask them. Next slide, please. Okay, so this is typical disclaimer that we use when we are doing presentations. Obviously, it's intended to be a general summary, but this is not a legal presentation, or you should refer to any published materials if you're looking for current policy. Next slide, please. So again, just want to welcome everyone today. We will be providing resources during this call to assist with measure development and to facilitate a successful measure submission to CMS for consideration of inclusion into our MIPS program. So hopefully we'll give you some information about how to best submit your measure, as well as best opportunities to have it considered favorably and included in the program. Having said that, let me turn the call over to Dr. Ron Klein for the next part of the presentation. Thank you all.
Right, thanks, Dan. Next slide, please. Thank you, everyone, for joining today's seminar, or webinar, I should say. Today, I'll be reviewing the CMS strategic goals and priorities for quality measurement across all CMS programs. Next slide, please. So the CMS National Quality Strategy is divided into 4 priority areas. 1 is equity and engagement, 2 is safety and resiliency, 3 is outcomes and alignment, and 4 is interoperability and scientific advancement. So in terms of equity and engagement, we want to advance health equity and whole person care. And, you know, as a physician, I just like to keep it simple and say that just means we take care of all of our patients to the best of our ability. So that's really, to me, what equity is. Engagement is that we engage with communities and individuals so they become informed health consumers and partners in their care. Our aspirational goal is to achieve 0 preventable harm. While we're on the way to 0, we can certainly reduce things, and that's a worthy goal as well. We want to enable a resilient healthcare system. We learned during COVID just how fragile our healthcare system is. And we want to build more resiliency into our system in general, and God forbid, any future, public health emergency. We want to improve outcomes. We want to improve quality and health outcomes across the care journey. Seems like a reasonable goal. We're trying to align our programs align and coordinate our programs across care settings. That's intended to minimize burden in terms of some of the quality metrics. We're trying to create interoperability and transition to a digital and data-driven healthcare system. And I'll just take a slight 10-second detour and say there was a publication in JAMA in June or July of last year that showed that digital health measures have roughly 1/15 to 1/20 the cost of other types of administrative measures. So trying to get to a digital, version of quality measurement really gets us to that vision of clinicians just taking care of their patients and letting the rest flow seamlessly from their work. And then scientific advancement. Medicine is changing very rapidly, and we want to transform healthcare using science, analytics, and technology. Next slide, please. So how do measures contribute to the CMS National Quality Strategy, and how do they drive improved performance? So measures drive quality and outcome improvement. It's often said that you can't improve what you can't measure. So this is a way of actually seeing how we're doing beyond just simply waving our hands and saying we're doing great. They support ongoing performance improvement efforts and goals. Most programs start as incentives or pay for reporting, meaning you get paid just simply for reporting, and then they transition to pay for performance, meaning you get paid depending on how you do. Measures inform folks. Transparent public reporting informs consumers in making their healthcare choices, and that's probably most familiar to you to the various different Care Compare or STARS systems that allow consumers to see how they're doing. And I know certainly that healthcare facilities pay very close attention to their STAR rankings, and so hopefully that drives improvement. Measures are for accountability in the sense that they incentivize and penalize for performance. Measures link to quality as payment as opposed to just pay for volume. And the CMS goal is to have all healthcare payments in an advanced value payment model. So high quality, high safety, good experience, and decreased cost. Next slide. So what are the characteristics of good measures? They have high impact, right? We're going to spend all the time and effort to create a measure, and everybody's going to report it. We want to make sure it has an impact on people's health. It should be meaningful to, and that may be the better word for me, is relevant to clinicians and patients. There's so many different specialists out there. We want to have quality measures that are relevant to their work. Quality measures should support scientific evidence and best clinical practice. That seems obvious. There should be no unintended consequences. That's always the tough part of measures. They should be valid. They should be reliable. They should be feasible. There should be appropriate risk adjustments. So since we know there's a great variability in patients, and they should be appropriately attributable to the accountable entity. Next slide. So what are the future directions for MIPS? MIPS value pathways, I think originally was put in a rule, I think back in 2020 or 2019, and then COVID hit and a lot of things were put on hold. So COVID went live for the first time. I'm sorry, MIPS value pathways went live for the first time in 2023 reporting period. So we're now just starting to collect the data on MIPS value pathways. As of 2024, this current year, we have 16 different MVPs. Subgroup reporting will be required in 2026. It's currently voluntary. And there is direct measure stratification based on equity. And there are some confidential feedback reports to hospitals that are beginning to let them know how they're doing based on different patient populations they care for. As I mentioned before, that we're trying to move toward digital measures. And there is the US CDI, the US Core Data for Interoperability, that is creating basically a uniform template for information. And we're trying to have our digital measures follow that as much as possible. And there's also an interest in patient-reported outcome performance measures. So obviously trying to understand how patients feel they're doing. If it's a knee replacement and the orthopedic surgeon thinks they're doing great, but the patient doesn't think so, then both of those are important voices. And we're trying to capture those as well. And with that, I will pass it on to PIMS to take this further.
Thank you, Dr. Klein. Next slide, please. This is Laurel with the PIMS team, and we are going to start with a call for measures overview today. So next slide, please. So each year, CMS provides the opportunity for interested parties to submit measures to CMS for consideration and potential inclusion in a CMS program. The Meaningful Measures 2.0 framework serves as a guide to evaluate each measure for inclusion on the Measures Under Consideration or MUC list to ensure that the selection of measures pursues and aligns with the agency's priorities. Through setting the program needs and priorities, CMS encourages interested parties to take this into account when developing measures and submitting them for consideration of inclusion on the MUC list. The CMS quality measurement strategy is continuing to drive toward patient-centered, value-based care through the development, selection, and implementation of measurement that includes accelerating the transition to digital measures, as Dr. Klein mentioned, alignment across CMS programs, representing the patient voice and meaningful outcomes. Next slide, please. The MIPS annual call for quality measures process asks interested parties, including clinicians, professional and medical societies, researchers, and consumer groups, to submit quality measures for consideration in the quality performance category for MIPS. An extensive review process is completed for each submission to ensure the measure can be reliably implemented to assess clinician performance and that the measure will be meaningful to the intended reporting clinicians. I now will turn it over to Allie from the cost team to review the next slide.
Next slide, please. So similar to the MIPS annual call for quality measures, there's also a MIPS annual call for cost measures. This is again an opportunity for interested parties to identify and submit measures for CMS to consider for use in the cost performance category. This was established in the 2022 physician fee schedule final rule and would refer you there for additional guidance about measurement priorities and requirements, though we'll also touch on that a bit more as we go through the presentation. And I'll pass it back to Laurel to go through a bit more about the process.
Thank you, Allie. Next slide, please. We wanted to provide a high-level timeline for a typical year in which the call for measures opens in January. So it is currently open for submissions. Within the March and April timeframe, CMS holds educational webinars with the call for measures coming to a close in May. We use July and August to review the measure candidates and evaluate how the measure aligns with CMS's needs and priorities. We will dive into that topic a little more in the upcoming slides. By September, we provide feedback to the submitters, and the approved measures are placed on the MUC list, which enters the CMS HHS clearance process. Typically, the MUC list is published no later than December 1st to gear up for the consensus-based entity, or CBE, pre-rulemaking measure review, or primer, meetings that occur in December and January. Submitters are invited to the primer meetings and are expected to attend to provide information on their MUC list measure as needed. The primer recommendations are then published in February. The measure recommendations are provided to CMS with the overall goal to maintain transparency and encourage public engagement. CMS then reviews the primer recommendations, and the rulemaking team makes final determinations which MUC list measures will move forward to be considered for the MIPS program. Measures that are finalized during rulemaking will be implemented and available for reporting the following year. Next slide, please. To be considered for inclusion as a MIPS measure, a submitter is required to submit a few different items. First, of course, we need the measure information, along with a peer-reviewed journal article template for quality measures. All measures need to be fully developed and tested at the clinician level and feasible at the time of submission to the call for measures. There may be additional outreach to gain clarity if the review team has questions as the measures are evaluated. Measure submission is within the CMS Measures Under Consideration Entry, Review, and Information Tool, or MERIT, for the 2024 call for measures. Moving on to after the measures are submitted, if the candidate measure is placed on the MUC list, the submitter is expected to attend the primer meetings just referenced in the timeline. This allows stakeholders and committee members to ask questions, provide feedback, and fully understand the measure prior to engaging in the voting process. Finally, if the measure is proposed and finalized through rulemaking, the measure steward would maintain the measure through the annual revision process. This process ensures the measure aligns with current clinical guidelines. The coding is updated as there are annual revisions to ICD-10 and CPT codes, etc. We do encourage coordinating measure changes across collection types for quality measures, governing bodies, and other CMS programs, as this will continue to reduce reporting burden. Additionally, we request attendance of the measure stewards during the measure steward meeting hosted by CMS as scheduled. I'll now pass to Joel Andrus from CMS to discuss MIPS ECQM steward expectations.
Thank you, and good afternoon. Next slide, please. Thank you. Because of the specialized reporting nature of ECQMs, there are a number of specialized expectations for submitters who wish to have their measures considered for inclusion within the program. Included among these is a strong understanding and the ability to apply ECQM data standards, including the quality data model, clinical quality language, and fast healthcare interoperability resources, or FHIR. It's necessary that you're able to make and test technical changes using specific tools that CMS supports and maintains for these purposes, including the MAT, or Measure Authoring Tool, Bonnie for testing, and the Measure Authoring Development Integrated Environment, or MADI, which is intended to take on the responsibilities for both in the future, and as well as the Value Set Authority Center, which maintains the set of active value sets for use and implementation of the measures. It requires that you be ready to participate in the annual update process, which, as its name indicates, occurs annually and requires participation throughout much of the year, and involves a number of steps within the process that require engagement with CMS and its contractors to ensure that measures are updated according to evolving data standards and maintain fidelity both with those standards and with the implementation requirements at CMS. There's an expectation that you will adhere to the timelines and processes that we set forth for that annual update, which can vary slightly from year to year, using both the QDM and FHIR-based measure specifications. There's also an expectation that you're able to support response to interested parties' questions on the measure throughout the year, which means we get a lot of questions from stakeholders who are interested in measures for a variety of reasons. And we typically receive those through our help desk and coordinate with measure stewards when necessary in order to respond to questions about them. And then finally, as MADI begins to come online, there's an expectation that you will support the migration of measures and testing assets from MAT and Bonnie to MADI in order to support the continued implementation requirements for the measures in the program. And with that, I'll pass it back to Laurel to continue the presentation.
Thank you, Joel. Next slide, please. We're now going to move on to some measure requirements. Next slide, please. Measures that are fully developed are highly preferred by CMS. This definition includes the below with no changes needed to the measure specifications based on the results. Critical data elements should have person encounter level testing, which can be completed utilizing either validity or reliability testing. In addition, at the measure score level, there should be completion of reliability testing at the accountable entity level. Also, completion of empiric validity at the accountable entity level. Please note that while face validity does not meet the fully developed criteria, it will be temporarily accepted for new measures. Next slide, please. For those measures that are based on survey data or patient-reported tools, it would be expected that the survey or tool has also been tested. Please note, if you wish to proceed with a submission for a measure that is not fully developed, please provide additional testing or additional details regarding the state of development within CMS Merit. Next slide, please. On to some more measure testing. As mentioned, for a measure to be considered, it must be tested at the clinician level, which is the entity level for MIPS, at the time of submission. Reliability testing ensures the measure can reproduce results. For example, measure score reliability can be demonstrated by signal-to-noise ratio, which shows the ratio of variability in the measure due to true differences in performance and measurement error. We also require a measure is valid and accurately represents the concept and achieves its intended use. We would direct you to the CMS MMS Hub for additional guidance on testing and have included the link within the resources section of this slide deck, as well as on slide 11. Testing of the individual data elements in the final performance of the measure should also be completed to ensure accurate capture of measure components. I will turn it back over now again to Joel from CMS for some MIPS ECQM requirements.
Thank you very much. Can we take the next slide, please? Thank you. So as a reminder, there are some basic requirements for ECQM readiness when they're being submitted. The measure output must be provided in the health quality measure format using existing ECQM standards, including the quality data model and the CQL expression logic. We've provided a link here with the latest ECQM standards on the ECQI Resource Center as applied toward various performance periods, including 2025. Data collection mechanisms must be able to transmit and receive requirements as identified through MIPS regulations, so be familiar with what is laid out within the rule there. You are also going to be expected to provide MAT output to include HQMF human readable files and provide Bonnie test cases, which are capable of achieving 100% passing and 100% coverage within the Bonnie tool. You must also identify all value sets required for the measure. And though it's not required, we recommend that you also provide ECQM FHIR specification, either using MAT or MADI output. For testing, you are required to submit feasibility testing using the CVE's feasibility scorecard. And reliability and validity testing is expected that meets the definition of a fully developed measure as discussed previously. We've provided links here as well that provide you with additional measure resources, including links to all of the tools that we've mentioned here and the ECQI Resource Center serving as a clearinghouse of information for the existing measures that we currently have in the program. Next slide, please. Thank you. So we had a question earlier come up in the Q&A, and I'll take a chance here to update on that. We've been talking about moving toward digital quality measures for some time, not just in the context here, but elsewhere as well. Part of that is transitioning our ECQMs to FHIR, or the Fast Healthcare Interoperability Resources. This is a new data model that we believe will provide a significant advancement in the feasibility for collecting and sharing data elements for measures, while also breaking them out of the silos that quality measure data has historically been locked into. FHIR combines a simple framework of building blocks or data elements using technology to standardize how healthcare data can be represented and shared, and more importantly, can be utilized individually and distinctly rather than being locked into a single use case. In other words, the data are reusable. It's flexible enough to be used across a variety of EHRs and other healthcare exchange platforms, and allows us the flexibility to represent our quality measures, but also to be utilized for a number of other purposes. So what is the impact to the CQMs and reporting here? Well, the primary impact that we would expect to see in the future is that instead of being represented through quality data model data elements and the QRDA reporting standards, we would expect FHIR data model and FHIR reporting requirements to be used to represent or report ECQM data. That's one of the reasons we're talking about the option to represent your data as a FHIR specification through either MAT or MADI output. The FHIR standard has the potential to reduce overall burden on measure developers and implementers by providing faster real-time access to quality data. It allows us to align data exchange standards with clinical data support initiatives and other utilizations of the data. and allows us to also automate the retrieval of the data and the submission of the data for our quality programs. For more information on the transition of ECQMs to FHIR, you can visit the link we provided here to the ECQI Resource Center, and please reach out with questions to the help desk as well if you don't get the opportunity to present them today. And with that, I'll hand it back over to Laurel.
Thank you, Joel. Next slide, please. Since the 2020 call for measures process, submitters were required to link their MIPS quality measures to existing and related cost measures and improvement activities as applicable and feasible. Submitters are required to provide a rationale as to how they believe their measure correlates to other performance category measures and activities as part of the call for measures process. This will aid in the development of robust and cohesive MIPS value pathways, or MVPs. Submitters may also link the measure to a finalized MVP. We'll discuss the transition to MVPs in the next in the presentation, but wanted to note this requirement when you submit your quality measures. Next slide, please. And the next slide. As most of you likely already know, CMS is transitioning to MIPS value pathways, otherwise known as MVPs. The goal of MVPs is to create more cohesive participation experience by connecting activities and measures, resulting in a more value-focused program with reduced selection burden. MVPs are a subset of measures and activities established through rulemaking. The MIPS program aims to drive value through the collection, assessment, and public reporting of data that informs and rewards the delivery of high-value care. Within MIPS, we intend to incentivize clinicians for provision of healthcare services in a way that drives value by linking performance on cost, quality, and patient experience of care. So how do we take that into consideration during the call for measures? We will look to see if the measure candidate aligns with the current or future MVP topic, and by looking to see how it complements the linked improvement activity and cost measure. We also look to see if the measure fulfills a gap area within the MVP framework. This will be an important link moving forward as we transition away from traditional MIPS to MVP reporting. We encourage reference to the MVP needs and priorities document posted on the QPP website, and the zip file that document is contained in is also linked here on this slide. Next slide, please. We will move on to some considerations that are taken into account during measure evaluation. Next slide, please. Each year, CMS assesses the quality measure inventory and identifies specialties and clinical topics that are not widely represented within the MIPS measure inventory. We would request measures that support these measurement gaps. During our initial review, we are seeking measures applicable to these specialties and topics listed here on your screen. The MVP needs and priorities are also considered, as we just discussed, and you can refer to that link provided on slide 25. Next slide, please. In addition to the specialties and clinical topics on the previous slide, CMS assesses the quality measure inventory for alignment with priorities and focus areas. These include increasing the number of outcome and digital measures in the inventory, looking for measures that represent care coordination, communication, and team-based care, new measure options for topped-out specialty areas, measures that focus on or address health equity, COVID-19, and the patient voice. Next slide, please. As stated, we are seeking to move towards more outcome-based measures to include patient-reported outcome-based performance measures that utilize patient-reported outcome measures, or PROMs. Patient experience measures aim to improve customer experience and support innovative approaches to improve quality, accessibility, affordability, and most importantly, empowering the patient and the clinician to make decisions about their healthcare together. This incorporates that patient voice, which is a priority within CMS. Next slide, please. CMS also aims to reduce burden of reporting for clinicians. We have added administrative claims measures to the inventory, which do not require additional action on the behalf of the clinician, but are automatically calculated using claims data. Additionally, implementing digital quality measures that leverage sources of health information that are captured and transmitted electronically via interoperable systems will also assist in this effort. CMS continues with maintenance of current MVPs and introduction of new MVPs to assist with measure selection and create meaningful patient data. By also aligning measures across programs, those clinicians who participate in multiple programs will have decreased burden, as they will not have to implement the same measure concept in multiple ways based on the program. Next slide, please. Okay, so each year we do receive and review measure candidates where we provide consistent feedback to combine or revise measures. We wanted to talk through some typical detours to consider when developing a measure so that it has a better opportunity to move forward to the MUC list and eventual MIPS implementation. So we've kind of organized these slides into don'ts and do's, or do's and don'ts, if you will. The first on this slide is don't split compatible clinical processes into different measures. For example, the results of 3 different tests required for a standard of care should not be separated into 3 different measures, but a single comprehensive measure. Do explore opportunities to develop a composite or multi-performance rate measure. A current example of a composite measure in MIPS is quality measure 441, ischemic vascular disease, or IVD, optimal care. This measure takes a more comprehensive approach into managing and caring for patients with IVD by assessing that blood pressure is controlled, tobacco use cessation or non-use, and taking aspirin, antiplatelet, and a statin unless contraindicated. What we don't want to see is these 4 components submitted as 4 different measures. Next, we don't want submissions that duplicate or are one-offs to existing MIPS quality measures. We really encourage collaboration with MIPS stewards to be inclusive of appropriate clinical settings and patient populations. For example, if a measure doesn't contain the inpatient setting, but you feel it applies to that setting, we don't want to see that measure submitted as a separate measure, but rather reach out to the measure steward to see if they are open to expanding the clinical settings represented. And the third row on the slide, as these measures are submitted, we do look at the burden they may pose to clinicians or groups, and we would encourage the development of measures that also takes that into consideration. And lastly, on this slide is an important aspect of measure development. Please evaluate your measure for any unintended consequences. For example, a resource use measure that deprives oncology patients with shortness of breath of palliative oxygen therapy. Do assess the measure for a need for the appropriate denominator exclusions and/or exceptions. Next slide, please. Moving on to the next slide of do's and don'ts. First is do not submit a measure that only captures an assessment or that a survey was completed, or a measure that focuses on a clinical process that requires just a checkbox or documentation with minimal link to an outcome. As previously mentioned, we're looking for outcome, patient-reported outcomes, or intermediate outcome measures. We will not likely move these submissions forward and will request the measure is updated to emphasize a robust quality action or outcome. An example of a measure that uses multiple performance rates to capture an assessment rate separately with an inclusion of robust quality action is MIPS measure 226, tobacco use screening and cessation intervention. The first performance rate is the percentage of patients 18 and older who were screened for tobacco use 1 or more times within the measurement period. The second performance rate is the percentage of patients 18 years and older who were identified as tobacco users who received tobacco cessation intervention on the date of the encounter or within 12 months, in the previous 12 months, excuse me. The third performance rate is a percentage of patients 18 and older who were screened for tobacco use 1 or more times within the measurement period and who received tobacco cessation intervention if identified as a tobacco user on the date of the encounter or within the previous 12 months. So as you can see, if delineation of an assessment completion is important, there are opportunities to provide more granular data through multiple performance rates to the clinicians. For the next item, measures should align with current clinical guidelines, and if not, it would not be considered for the MUC list. For measures that are already in MIPS, each year during the maintenance process, the measures should be updated to align with current clinical guidelines. If a measure remains misaligned and likely produces misleading results, it may be suppressed until the measure is updated. While we do not score these suppressed measures, it does place burden on the clinician to collect the data that may not contribute to their final MIPS score. We do rely on the measure stewards to alert CMS of guideline changes or issues. All components of the measure should also be considered for evidence, or should also consider the evidence. For example, a denominator exception for a medical reason should be precisely defined and evidence-based. A broadly defined medical reason, such as any reason documented by the clinician, may create an uneven comparison if some clinicians apply reasons that may not be evidence-based. Moving on then to attribution. Attribution is the assignment of the results of a measure to a reporting clinician or group. MIPS is a clinician and group-focused program, and we want to implement measures that are attributable to the clinician, group, or virtual group. For example, we've seen measures that look at medication shortage or equipment supply, which does not speak to the care of the clinician that the clinician or group is providing. These types of measures would not be appropriate for the MIPS program. And lastly, on this slide, we also ask that you do not submit a measure that is a never event with no variability between clinicians' performance. While we never want a fire in the operating room, this occurs so infrequently that it is not a meaningful measure. When looking at complications, measure developers should ensure they are trying to close a gap in a given complication or event. They are important measures, but we also have to consider the method in which we score the clinicians and groups. If there is less than a percentage separating the top performer from the bottom, it is hard to say one clinician is doing significantly better. Next slide, please. Okay, moving to the last slide of the do's and don'ts. First, on this slide, we do not want to see measures that assessing a standard of care or a measure that's considered low bar. This relates back to the consideration of how we score MIPS. If there's little variability or gap, it's hard to differentiate performance among clinicians. Measures should ensure a performance gap exists through testing and investigate opportunities to revise measures to include a comprehensive and robust quality action. Lastly, while measures at any level of development may be submitted to the call for measures, CMS strongly prefers measures that meet that fully developed definition described earlier, with all applicable testing completed at the time of submission. Next slide. Moving on to some other considerations during the evaluation process. As mentioned, we request that performance data is included within your submission. Measure performance and evidence should identify opportunities for improvement. CMS does not intend to implement measures in which evidence identifies high levels of performance with little variation or opportunity for improvement. For example, measures that are topped out. Also, in developing measures, we would like you to consider the tools used in a measure. They should be standardized, validated tools that are non-proprietary. Consideration should also be given to ensure the measure is feasible for implementation within the MIPS framework, meaning it should represent a clinical topic that is a CMS priority or represents a gap in the MIPS measure inventory or MVP inventory. The measure should be analytically sound, producing performance scores that reflect comparisons across peers and fit within the MIPS scoring system. Lastly, the measure should be intuitive or show high face validity. This is important as this information can be viewed by a patient within CareCompare. I will now turn it back over to Allie to review a little more about the call for cost measures.
Thanks, Laurel. Next slide, please. So I'll talk a little bit about the considerations that CMS takes into account for cost measures. These build upon what you've heard generally about the call for measures and call for quality measures. So for the cost measure inventory, CMS does consider the extent to which measures further the goals of the CMS meaningful measures framework and the extent to which the submitted measures are consistent with other measures in the cost performance category. Some of the features that the measures currently in use share are that they define episodes based on medical codes that determine the patient cohort and identify a clinician-patient relationship for a particular type of care that's being assessed. Cost measures also specify which costs are included in the measure. and then apply exclusions to ensure completeness of data in a comparable patient cohort, as well as using risk adjustment approaches to account for differences in clinical and other risk factors that affect cost. Also, measures should not be duplicative or redundant with a current cost measure. And CMS prefers measures have the potential to be used in an existing or future MVP to help assess the value of care for a defined clinical topic. Next slide, please. In terms of considerations for measure construction, testing, and specifications, a few questions to consider as you are developing and submitting measures is, does the submitted measure have complete specifications and the required testing information? Do the specifications have clinical face validity, consistency with practice standards? Do they allow for consistent calculation and reproducibility using Medicare claims data? Additionally, would the testing information in the submission demonstrate sufficient variation to be able to distinguish performance across clinicians? Could clinicians know which measures or patients they would be assessed on based on the specifications? Does the measure include the cost of services that reflect the role of attributed clinicians? Can clinicians readily understand the construction methodology? And then additionally, can the measures be presented in such a way to convey clear information to clinicians to help them improve their performance? Next slide, please. Here we've listed on the slide a handful of specialties with limited episode-based cost measures that are applicable to them based on empirical analyses of administrative claims data. So we would encourage folks to take a look at these specialties, which are also listed in the call for cost measures document, and consider submitting cost measure concepts for these specialties. I'll pass things back to Laurel again and on to the next slide.
Okay, go ahead to go to the next slide, please. Okay, so on this slide, we included some very helpful resources, including the CMS Hub and several of the call for measures documents that should be helpful in when developing your measure and in submitting a successful candidate to CMS for consideration. I believe a few of these links will be shared here in the chat, so that, but you can also, we'll have them once the slides are posted. So that concludes, I believe, the presentation. We can move to the next slide, and I think we'll move on to the question and answer session.
All right, thank you. We're now going to start the Q&A portion of the webinar. So as a reminder, you can ask a question using the Q&A box, or you can raise your hand to ask a question via the webinar audio, and we will unmute your line. We do have a couple of questions in the queue. The first one is for Colleen, and it's asking, how and when would someone make suggestions to change or alter existing quality measures?
Hi, this is Colleen from the PIMS team. There's a couple different ways that you can go about making suggestions to change or alter an existing quality measure, one of which is to reach out to whoever owns that measure or the measure steward and start discussions with them to see if there's potential for revising that measure in future rulemaking cycles. Another option is to just submit comments about the measure and requested changes during that notice of public comment of rulemaking. And even if the question is deemed to be out of scope for that rulemaking cycle, we will take that into consideration and share as appropriate and applicable with the measure stewards. So two different ways there. If there is an issue with the measure, you can also just submit a ticket to the QPP help desk and receive guidance there.
Thanks, Colleen. Our next question's also for you, actually, and that question reads, must quality measures always be a numerator over denominator? Can developers submit measures as a point or percentile scale?
So there are a few different nuances within this question, and we have different analytics that can be utilized within the program. So I can give a bit of an overview, but for the most part, this is going to be a measure-specific question and a discussion about how to best implement a measure within MIPS. We do have proportional and non-proportional measures in MIPS. However, we do prefer proportional measures as they work better within our scoring analytics that we use for performance determination, and they are more meaningful to clinicians. That said, we do also have continuous variable and ratio measures to a very small extent if that is necessary for the measure analytic for implementation. We do have to have some sort of denominator and numerator for the purposes of ensuring that all measurement reporting requirements are met. So again, a few things there. There are some rules that we have to follow in order to make sure that we can implement within the program. But this is going to be a very nuanced answer to each individual measure that is submitted and how it works best within the program.
Thanks, Colleen. We do have another question for you, but before that, just wanted to quickly remind folks who are on the line that you can raise your hand and we will call on you to ask your question out loud. Or you can put your question in the Q&A box and we will answer your question over the phone. So Colleen, this next question for you asks, for the Pro-PM measure, that accountable level is clinician group for testing. Do we have to test at the individual clinician level for submitting to MIPS quality?
Yes, so for submitting quality measures for MIPS, we do require that it be tested at the individual clinician level, as that's the level of analysis for the program as a whole. You will see that we do have a couple nuanced measures that are group level only, and they do require a threshold for reporting purposes, but for our individual quality measures, this is the level of analysis that we require regardless of the type of measure is, if it's a Pro-PM or an intermediate outcome or process measure. We do look for that individual clinician level testing.
All right, thank you. And then I see we have a question on the line from Christine. Christine, we have unmuted your line if you would like to unmute yourself.
Sure, thanks. So we have a very large tin. I put this in the Q&A, but it's easier to ask the question than type it out. So we have very large tins, Hackensack Meridian Health. One of the tins is more than 1,000 providers. And as we're looking at the MVPs, in that when we choose our subgroups for like cardiology, endocrine, that's the quality side of the MVP program, right? When we're submitting the performance improvement activities, that's historically tin based. So 50% of the providers in the tin. So also in the tin, we have hospital facing providers. So it's difficult to work with because it's hospital and ambulatory providers. So when we choose a subgroup of an MVP, say cardiologists, ambulatory practice cardiologists, is the performance improvement activity only for that MVP subgroup, or is it still for the whole tin? I hope that question makes sense. Sorry, did I break CMS?
Hi, this is Colleen from PIMS. I will jump in and then anyone else, please follow up. So this particular webinar is for the purposes of the annual call for quality and cost measures. So we do not have all the necessary SMEs on the phone to answer MVP and subgroup reporting questions. So I would encourage you to reach out to the QPP help desk and submit your questions there to ensure that it gets to the correct teams for answering.
Gotcha, thank you.
All right, thanks everyone. So that's gonna conclude our Q&A portion of the webinar. So I'll turn it back over to Dr. Dan Green to conclude the call.
Thank you. Just want to thank everyone for attending today's session and for the thoughtful questions. Please do submit a help desk ticket if we didn't get to your question or if you find you need more clarification. We'll look forward to receiving your self-nominated measures, and we wish everyone a good day. Thank you.